continue. Some of you were here, some were not here. In mine is page 11. Everybody has same page or any other number? So those who were not here, just open up. After is hypertension. We talked about gestational hypertension. And what are the complications of patient when they're going in pre-eclampsia? That's important. And I mentioned that yesterday. If your patient has hypertension and pre-eclampsia, what are the complications you will monitor for your patients are? Number one, abruptio placenta. Remember that? Abruptio placenta. And it's on page number 10. And complication, DIC, disseminated intravascular coagulation. Then I said placental insufficiency and intrauterine growth restriction. Those are very important, that because we must know when somebody has hypertension or preeclampsia, what are the complications you're going to monitor. So look on that. And medication, I talked about magnesium sulfate yesterday. And I said, what do you monitor when you're giving magnesium sulfate? 3 things. Number one, on your page number 11, right on the top, toxicity of magnesium sulfate are absence of DTR. Number 2, low respiratory. Number 3, low urinary output. So you got to memorize like that. So those are important. If patient is in eclampsia, you still give magnesium sulfate. What is the normal level? They want to keep it for magnesium sulfate for 4 to 8 to 9 to 6 is okay, because they don't want to be lower the level. And what is the antidote for magnesium sulfate? Calcium gluconate. What is the complication also you can have when they have preeclampsia? I said the word HELP syndrome. Remember that? What is HELP syndrome was elevated liver enzyme. There is a hemolysis, bleeding problem. And what would be high here, low here? Platelets. Platelets are low and liver enzymes are high. And what would you monitor patients when they have this syndrome? They have pain in the right upper quadrant. Patient is bleeding. And what do? Patient should be in the hospital, treated, given them the blood transfusion, and also they may have to do the delivery of the fetus, but do not palpate the stomach. Now I'm going to move on the same package. So we are finishing today OB, and I wrote it down. Here we start incompetent cervix. You guys have in your package. And what is incompetent cervix means is, underline the word premature. Premature dilation of the cervix. Cervix dilate before time. So what happened? Mother cannot keep the baby and they lose the baby faster. So what is the problem? Incompetent. The cervix is not competent. Cervix is not good and they have incompetent cervix. And what is incompetent cervix is? Dilation of cervix. And what do we do and when? 4th or 5th month of pregnancy. And it can be a structural defect or defect of the uterus. So it's a defect of the uterus. It's on page number 11. And those who were not here yesterday, just look where you will see the word HELP syndrome and eclampsia. Underneath it says incompetent cervix. Data collection is what? Vaginal bleeding. And very important answer, fetal membrane visible through the cervix. Cervix dilate and they can see the fetal membrane. Lot of question, what is the incompetent cervix? Answer is you can see the fetal membrane through the cervix, and cervix is dilated, mother start the bleeding. And also I want you to add there underneath where it says premature dilation, some of the question they said cervix cannot take the weight of the fetus. That's what happened. The cervix cannot take the weight of the fetus and it dilates early. How the wording? Wording question may not be exactly the same, but remember the cervix is weak. They're not able to hold the baby and the cervix dilate early and mother will not be able to keep the pregnancy and for timely. Now, what do you do if mother has a problem? Is number one is bed rest. You got to give the bed rest. Hydration is important because if they're bleeding, we got to give fluids or the blood transfusion. Very important word is tocolysis. Tocolytic medication. What is tocolytic medication are? They're reducing the contraction. What is tocolytic? It's relaxing and the uterine contraction. So what is it lowering here? Inhibiting the uterine contraction. Such as what medication comes in tocolysis are, underline the word breath-in. Breath-in is one of the medication. And also they will do that. So what drugs they can give? The drugs which can relax the uterus. That means mother is not going to go into labor. So wherever your labor is going fast and mother is not ready yet, so what medication they can give? You have drugs to increase the contraction, you have drugs to decrease the contraction. The drugs are called tocolytic medication. And what is the side effect of breath-in? I want you to write down their tachycardia. So you got to monitor their pulse rate, monitor the patients, and side effect is tachycardia, and write down on the side. What do they do for the mother to save the pregnancy? Is called, there are two words here, McDonald and Schrodinger. In between you have the word is called serlage. So underline the word, what is the treatment is called? Serlage. Now they can tie the ribbon in one and the other one they can sew the area. So what do? They close the cervix and the word is called serlage. So your question, what is incompetent cervix? Mother is going to lose the baby. So what do? Because the cervix is weak, they tie around the ribbon or they will close that part. And that is called, the word is serlage. And why is done serlage? You can highlight the word to close the cervix. What are we closing here is the cervix. And for serlage is done 10 to 14 weeks gestation. And ribbon placed around the cervix. After serlage, what do you teach the mother? Then you will say refrain from intercourse. No sex after they have serlage done. And also avoid, underline the word standing, lifting, that's important. And how long they keep the serlage? Around 37 weeks. So you got to teach the mother what to follow up, that avoid any kinds of lifting, standing too long, avoid the intercourse on that, and also they can leave it. For how long? They can leave it for 37 weeks, and maybe after 37 weeks they can remove it. Once they remove the serlage, they have to retie it every time the mother gets pregnant. Second choice is they don't remove it. If they remove serlage, they have to replace every pregnancy. If they don't remove it, then what do? They have to have a C-section. Everyone is okay? So what is a serlage? In your mind, immediately we know the cervix is very weak. And what do? The treatment? Serlage. What do you avoid the mother? What would you teach them? Is standing, lifting, and sexual intercourse. And they can remove it. If they do remove, then what do they have to do? They have to put it back every time when the mother gets pregnant. And they can also leave it, but if they leave it, they have to do the C-section. So the wording is, serlage word is important here, incompetent cervix word is important to know, and what is the treatment is the serlage is the treatment. Now I will move on some wording on infection. We talked few wording in the earlier, but what are the infections are common? One is toxoplasmosis. So what is toxoplasmosis? Early sign or highlight the word, the rashes and the flu-like symptom. And how does that toxoplasmosis comes? Second line, from the raw meat or eating raw meat or handling cat litter. Lot of question, you will see handling the cat litter. And so you will teach them to use the gloves, and prevent them is using or cleaning. When they're cleaning the cats, they must wear the gloves. And what does it lead to? It can lead to spontaneous abortion. So what is early sign of toxoplasmosis are flu-like symptom. How do they get it? From cattle litter or from the eating raw meat. And a spontaneous abortion can lead to, and second one is your rubella or German measles. German measles goes through the mother, from the mother to the baby during first trimester. If mother has rubella or German measles. And it causes, what does it cause? Second line, defect in the eye, heart, and also the brain. And what do you teach them is you give them the rubella vaccine to the mother after the delivery. And what do you teach them is wait for not 8 months, correct here, 3 months. So until 3 months, mother should not get pregnant. So rubella vaccine is given. Mother can feed the baby, is okay, but very important not to get the pregnant. Cytomegalovirus virus. Underneath we have cytomegalovirus virus transmitted to the fetus, and mother may be asymptomatic. So underline the word asymptomatic. So mother is what? Asymptomatic. And most infants are asymptomatic at the birth. So it's basically, it will show asymptomatic. But they will do the diagnosis. How? By the urine, and they will see low birth weight, liver and a spleen affected, jaundice, and it can lead to blindness, cytomegalovirus virus, and seizure. Very important, the blindness and seizure. And how do you treat them? Cytomegalovirus virus is a viral infection. So how do we treat them? By giving viral medication. Next page, we'll move on. And the next page, you guys have herpes. Now those are very important, and I will advise you, everyone, number 10, I gave you the questions, a very good question. And it's a lot of like infection control, so make sure you do those questions. And herpes questions are genital herpes, HSV3, caused by, underline the word, virus. Affect the vaginal area and the cervix. And what do they have? Blister. They can disappear, and they're in 2 to 6 weeks. And also they can affect systemic effect, fever. They will have fever, enlargement of the lymph nodes, and virus is transmitted through the birth from infected vagina. So when any questions you have on genital herpes, the mother has it, the answer would be, all your question is C-section. So we will move on. No vaginal exam. If mother has it, no vaginal exam. And may cause death or neurological impairment. So what is herpes can cause? Neurological impairment. And so you don't want to do any exam, and delivery question would be C-section. So how would you deliver the baby? Mother has genital herpes, she has lesion, and the blisters is avoid them having normal delivery, C-section. And if the lesions are on anal area or thigh area, you can deliver the baby, but you have to prevent them from contamination. But it's on vaginal side, no vaginal delivery. So everyone should know the herpes are viral infection, have the lesions. It can be on vaginal area, anal area, thigh area. But if there are the lesions are there, delivery should be done C-section. Next is sexually transmitted diseases, syphilis. And what is syphilis is caused by, underline the word Trypanosoma pallidum, which is called spirochete. Now, spirochete, Trypanosoma pallidum are the organism which is causing syphilis. Now, syphilis has 3 stages. We all should know simple way, because a lot of times they will throw the question, the stages. And the first stage is called primary stage or early stage. So remember, they can use the word primary or early stage. And what is in early stage is within 6 weeks. What is it here? Within 6 weeks. So we were talking about the herpes question. Everyone knows herpes is coming from viral, and lesions are there, no vaginal delivery. Number one, everyone should know that. Number two is I'm moving on syphilis questions are sexually transmitted disease. Very common questions, you will see that. And syphilis caused by spirochete. And the name is Trypnoma pallidum. There are a lot of books, they do ask these questions. So I would say, if you can figure it out, see some of the organism, you will remember. Number two is type syphilis has the 3 stages. Early stage is called primary stage. Sometimes they use the word primary, secondary, and tertiary. If they didn't use, they may say early stage and later stage. Tertiary is the last stage. So what is in the primary stage? I want you to highlight the word chancre. The word is called chancre, and these are like ulcers they have. So write down on the top, painless ulcer. So what is in the early stage they have? They use the word for the ulcers, chancre. And also, some of the questions I came across, they have painless ulcers. So they are painless. There are ulcers. And also highlight the word enlargement or lymph node enlargement. So early sign, everyone should know the wording is chancre. And painless, they are painless ulcer, and they have enlargement of the lymph node. What is secondary? Secondary comes after 4 weeks around, and patients start having low-grade fever. Now they have fever in secondary stage, and sore throat, headache, and rashes. They start getting more rashes, and pustules. They have more pus in there. Some of the questions they have, I was doing question, and I want you to add there. In the second stage, they have answer red rashes. So add there the word red rashes. And there was also one of the question in the secondary stage, and they had the answer patchy hair loss. Whenever you have rashes, the skin area, they start losing hair. So there is another, is losing hair or patchy hair loss. Like patches, wherever they have rashes, they lose the hair. Are we clear? So secondary stage is 4 to 12 weeks. They have low-grade fever. And also, I want you to remember, is sore throat, fever, muscle pain, but they do have red rashes, and also they lose hair, and they are having what? Patches of the hair loss. So patchy hair loss. Third stage is called final stage, which is called tertiary. So if they're giving you a question, tertiary stage, and they have headache, muscle pain, but what is very important here, underline the word heart. It involves the heart, nervous system, and leg cramping. Some question answer was sharp, stabbing, leg pain. I want you to add there because they have leg cramping. Patient complains sharp leg, in the leg, a stabbing pain. So there are 3 stages. Everyone should know the final stage, the heart is involved, nervous system is involved, and they have a lot of leg cramping, and maybe is the sharp stabbing leg pain answer. So 3 stages are there. Intervention, how do you diagnose them? The test is called VDRL. That is a test, and very important test is FTA, which is fluorescent and trypnosomal antibody absorption test. So test names are VDRL, but most of your questions has FTA, is fluorescent trypnosomal antibody absorbent test. How do you treat them? Is by penicillin. So it's antibiotic. So they have to be treated by antibiotic. Anytime they get infection, they got to get the antibiotic. So it's a sexually transmitted disease. Syphilis has 3 stages. The treatment of syphilis is by antibiotic. Penicillin is a choice of drug. And what are the 3 stages are primary, secondary, and tertiary. Secondary stage, they have more rashes, start losing some hair. And the tertiary stage, I said leg cramping and pain and involvement of neuro and heart affected. Gonorrhea is another disease, sexually transmitted, comes from gram-negative Neisseria gonorrhea. So underline that word, gonorrhea. Onset is 3 to 10 days after sexual intercourse. So it's a sexually transmitted disease. And mostly your question, male has dysuria and yellow greenish drainage. That's your answer for gonorrhea for male. Female have no symptom. They won't show symptom. And it can lead to, what does it lead to? So female are asymptomatic, they don't have symptom, but the male is important, the greenish yellow discharge. That would be in gonorrhea question. Now, what does it lead to? To the mother, pelvic infection, and to the baby's eye infection. And what is that is called, yesterday I wrote it down, ophthalmia neonatum. What is ophthalmia neonatum is the blindness, and that's why we put the eye medication when the newborn babies are born by to prevent from gonorrheal infection, because gonorrhea can lead to blindness. And the word is called ophthalmia neonatum. And culture, they got to do the culture for diagnosis. Treatment for gonorrhea is antibiotic. You can give penicillin, tetracycline, rocephin, vibramycin, azithromycin. These are all, mycin word are strong antibiotics, penicillin are strong antibiotics. Syphilis and gonorrhea, they both are treated by antibiotic. Condylomatous, the next one, and which is called the wart. Very important, the wart caused by HPV, highlight that word, HPV, is human papilloma virus. And what does HPV? It comes from skin to skin contact, but HPV goes for your cancer question. Underline, reason for vaginal and cervical cancer comes from HPV. Everyone should know, very common when I did oncology, and I said is all the reason for cancer we must know. For NCLEX, your cervical cancer and caused by HPV. Everyone, we must know that. And wart comes also from HPV infection, skin to skin contact. They are dry wart, and it affects on cervix area, vaginal area, and then we will go next page. How do you treat the wart? Diagnosis by biopsy and by looking at them. But the biopsy and pap smear is the good answer. And how do you treat them? Antiviral medication. Next is anti-neoplastic. Some of the treatment are done by cancer medication. Now when you have word 5F, I want you to add there the word 5FUO. This is full, the name of, this is anti-cancer medication, 5FUO. And polydiflin 20% or tincture benzoin, they can use it and not to use when they are in pregnancy, but that can be also used. So how to treat them is antiviral. So anytime they're giving what is wart R, coming from what wart are caused by HPV. And what is HPV can lead to cancer. So you have to monitor and assess the patient for cancer. Candida infection is common, vaginal candidas in pregnancy. Second line is, even you're giving antibiotic question. When you're giving too long antibiotic and strong antibiotic, it can cause candida infection. Are we clear? So what is the side effect of antibiotics are? Your candida infection and antibiotic. Diabetic patients, very easily they get candida infection. It's a fungal infection. Obesity, person obese, they can get easily infection. What does it cause? itching. Pruritus word is important, and white, cheesy, light discharge. So remember, in the babies, they have the thrush, those in the mouth. That's a fungal infection. That's a candida. What is candida infections are? Fungal infection, but when they have in vaginal, they have what? White, cheesy drainage. How do you treat them? Underline the word antifungal medication. What is antifungal medications are, is everyone should know, is nystatin or mycostatin. Mycostatin. These are your fungal medication, and that can be treated by fungus. So we all know candida's infection are fungal infection. How do you treat them? By antifungal medication. What kind of drainage the patient has? White, cheesy drainage. All your patient, you must use the gloves. Trichomonas infection. That's also comes from sexual intercourse and is caused by Trichomonas vaginal infection. Data collection. What kind of drainage they have in Trichomonas infection? That's important. Yellow to green frothy drainage. So the drainage are yellow and greenish drainage, and underline the word malodorous and frothy. And also it's a malodorous, and it can cause inflammation of the vaginal area. How do you treat them? By antibiotic. And Flagyl can be a choice of the drug. Any question with Flagyl? Flagyl is an antibiotic, but patient in your teaching question, no alcohol. So those who have not done it before, make sure you write down anytime in your teaching question. Flagyl is antibiotic. You can give your patient to treat them as antibiotic, but Flagyl is good, but when you're giving Flagyl, patient cannot have any alcohol. So I like it, everyone should know a little bit syphilis word, and also wart, HPV word is very important for exam. And the drainage, when they're saying trichomonas drainage, and that is greenish drainage, treatment is by antibiotic. And keeping cleaning your patients is always important. Peri-care is important. Now I will move on, some wording on abortions. And at least we should know the types of abortion. First is called threatened abortion. What is a threatened abortions are? Underline one word, spotting. The mother comes in, a patient comes in, she is only having a word, a spotting. That means she's not really bleeding. So when she's having spotting, you want to save the pregnancy. Everyone is okay? So what is threatened abortion? Mother comes in and mother is having what? Only spotting, and you want to save the pregnancy. So what do? Bed rest is your answer, and underline the word tocolytic medication. If mother is having contraction, you want to stop the contraction and save the pregnancy. What are the other tocolytic medications you have? Breathine, you have one, we said Utapor and magnesium sulfate. That also is for reducing the contraction. Now, inevitable abortion. So anytime you see the word threatened abortion, they're not completely losing the baby. You can save. So what would be the best thing is to give the mother bed rest, no lifting, no walking around, and stop the contraction because she is only having a spotting. That means we can save the pregnancy. But when we have inevitable, means you cannot save it. That means the no fetal heart rate. Mother comes in having no fetal heart rate, part of the fetus is already passed. So what is the treatment for inevitable abortion is DNC. They have to take it out. Incomplete, same thing, fetal demesis, but not completely, and they have to do DNC. Complete abortion, everything came out, so you don't need to do anything. Complete means everything is out. Septic means infection. And what do we treat with the abortion? Maybe the mother already lost the baby, but the septic means infection, and you got to treat the infection. Missed abortion is fetal demesis, but no expulsion of the fetus, and they have to be removed by surgical. Mr. Boston word, incomplete word, that means they have to remove it. Elective means for mother's health. Some reason they have to remove the baby. And for evacuation, that means they have to remove and take out the baby and plan to do the abortion. 5, for elective purpose. Elective means planned. Planned means when the mother's health is not good. Now we have talked about is the pre-labor testing non-stress test. So this is repeat, but let's move on to the next page. We talked about yesterday about non-stress test. But next page you have oxytocin challenge test, which is called stress test. It's called also the stress test. You can add an oxytocin. Yesterday we said non-stress test, and we were monitoring the fetal heart rate with the fetal movement now, and we asked the mother to press the button in the other test. Now today we will have oxytocin challenge test. What is the meaning oxytocin challenge test? Second line, they give mother Pitocin. And why? Maybe mother is not having contraction. So they give Pitocin, and they add the Pitocin in IV fluid, and they run the fluid every 15 minutes, 3 ml per unit. So even you don't know what they're running, but you must know that they start the drip to increase the contraction. Contractions in 10 minutes you are monitoring. If fetal heart rate are low, baby is in distress, the fetal heart rate is 160 and normal, and that means the test is going to be normal. Now, oxytocin challenge test means is you're giving Pitocin and you're checking the fetal heart rate. Are we clear? So that means his mother is not progressing in contraction, and after giving oxytocin, we are checking the fetal heart rate. Now, induction word, induced labor. And the meaning is mother is not in labor, and what are we doing here? Inducing the labor. How? By giving Pitocin, increasing contraction, and we talked about the drug yesterday, and it says prostaglandin gel. And what is prostaglandin gel is increasing contraction, but they also use the word soften the cervix. And when you're giving Pitocin or these medications should be given by drip. You want to control the drip. You don't want to give too fast. And monitor the mother's vital signs, especially the blood pressure and the fetal heart rate. Now I will move on fetal monitoring. Fetal monitoring means fetal heart rate. And what are the three? These three, everyone, we must know the monitoring of the fetal heart rate, and you have early, variable, and late deceleration. The meaning is early deceleration, the fetal heart rate is dropping, and that is early deceleration. Deceleration means is the fetal heart rates are changing. Now when they give you early deceleration is, I want you to highlight the word, it says head compression. When do you see is early deceleration? When the baby's head is going down, is moving. And what is it causing? Compression. And that's why you feel the fetal heart rates are dropping. So in your question, baby is moving down and mother is going in labor. What is a normal deceleration? Your answer would be early deceleration. What is the reason for early deceleration? Your answer is head compression. In which one you will see more, and you'll have the word cephalic. Cephalic means head. When you say cephalic presentation, that means the baby's head is coming first. So when the baby's head is moving down, the contractions are coming and fetal heart rate drops. What happened in the fetal heart rate? Underline in the second line, return to baseline. That means it goes down, but quickly it returns back to normal fetal heart rate. Do you have to do anything? No. Nothing we have to do. It's normal. Everyone is okay. No treatment is necessary. So what is early deceleration? I want everyone just memorize like that. Early deceleration comes from head compression. That means the baby head is moving down in cephalic presentation, and they might say the fetal heart rate is having deceleration but is returning back to the normal. That is your early deceleration, and they're normal. You don't have to do anything. But second one, you have variable deceleration. In the picture, they might give you, and the shape is more like V shape. And it says V-shaped decrease in fetal heart rate, and caused by, underline the word, cord compression. Now when we are using the word cord compression, the meaning is, right down on the top, prolapse cord. What is the reason here? Prolapse cord or cord compression. So when we are using the word cord compression, that is a variable deceleration. Now they give question, the mother is admitted. Mother is having a prolapse cord. What do you monitor? Your answer, we are monitoring variable deceleration. Are we clear? So what do you monitor is not good. That's a variable deceleration. And why? Because the cord is getting compression. What is getting compression? The cord, umbilical cord. And what does it lead to? Underline the word hypoxia. We are monitoring the mother for hypoxia. And what do? Knee chest position. You do have Trendelenburg position. You do also have knee chest position. You can add that. Knee chest position, or you will write down the word is here, is hypoxia, knee chest position, Trendelenburg. So first thing, put the mother in knee chest position or Trendelenburg position. What do you give the mother? Oxygen. Why? Because it's causing hypoxia. Number two, maybe you can give fluids and C-section and stop the Pitocin. And I want you to write down two more things here. Cover the cord with normal saline. What do we do? Cover the cord with normal saline. So cover the cord. You don't want the cord is drying, so cover the cord with normal saline. Now, next thing I want you to add there, also remove the presenting part. Remove the presenting part. The meaning is here, the baby's head is pressing the cord. And what they can do, the doctors, they can put it as a nurse, and we are removing the baby's head. So what are we removing? Presenting part from the cord. Because what happened? The cord is coming down, and it's a prolapse cord, and baby's head is pressing the cord. So what happened with the pressure? There's no circulation towards the fetus. So if you remove the presenting part, the circulation is going okay, and baby will not go in hypoxia. Everyone is okay? So what do we do? First thing, position. Put the mother in Trendelenburg position or knee chest position. Number two, give oxygen. Number three, cover the cord with normal saline. And number four, remove the pressure of presenting part. Everyone is okay? No pushing the cord. We are not touching the cord. We are not going to do anything with the cord. So what would happen when the mother is having prolapse cord? Your answer, everyone in your mind. Mother comes in with prolapse cord. What kind of deceleration baby is having here? Variable deceleration. What kind of deceleration you will see? V-shaped. And that will take a longer time to come to normal, and it will lead the baby or the fetus what? Hypoxia. And fetal heart rate will be dropping, and we can lose the baby. So what do we do? The first thing, position the mother. By the time you are preparing, mother is going for C-section. That's okay. But what is it important here is positioning, oxygenation, removing the pressure, and everyone remember a sterile technique. Why? Because you can lead to infection. Anytime, any question, whenever you're covering any organ in your question in NCLEX, what do you use? A sterile gloves. to prevent infection. So what is early deceleration? Normal. When is early deceleration comes? When the baby's head is coming down and is called head compression. What is variable decelerations are from cord compression. And what do we do for that? You prevent from hypoxia. Give the oxygen to the mother, remove the presenting part, cover the cord and positioning of the mother, and prepare the mother for delivery. If you have stop Pitocin, yes, you want to stop the Pitocin because you don't want mother to quickly have a baby because you may need mother to go for C-section. Are we clear? So these are your answers. So number 1 is early deceleration. Number 2 is variable deceleration. Now I will move on, late deceleration. What is the late deceleration? Dropping the fetal heart rate. And what is the reason for dropping the fetal heart rate? We have the word here is called uteroplacental insufficiency. That means there is a bleeding. Write down on the top, abruptio placenta. Sometimes they don't give you the word abruptio and they give uteral placental insufficiency. Immediately, what happened with the uterus? Mother is bleeding and placenta is not getting enough blood and baby is not getting enough is oxygenation. Are we clear? So which are the late deceleration is bad? Why? Mother is having what? Bleeding. And what is the reason for the bleeding? Could be abruptio placenta. So what do you monitor? Mother who is having abruptio placenta, your answer is late deceleration. What is another answer is here? Uteroplacental insufficiency. So what are we monitoring? Uteroplacental insufficiency. So and what does it lead to? Fetal hypoxia is leading to fetal hypoxia. Lack of oxygen. What do you do? Mother is bleeding. Number 1, first thing immediately you stop Pitocin. You must give oxygen to the mother and turn the mother to the left side. And what do you prepare mother for? C-section or delivery. Are we clear? So what is we talked about? Uteroplacental insufficiency. Everyone keep that word in mind. Because remember, in NCLEX, more is the wording. All exam, the wording is important. They may not like to give the straight word, mother is having abruptio placenta, and they love to throw this word uteroplacental insufficiency. Mother is bleeding, and placenta is not getting insufficiency. They're not getting is what is the blood circulation, and fetus is struggling for breathing, lack of oxygen. And so what are the abnormal fetal heart rate are? We call the word deceleration. Everyone is okay? 3 deceleration. Early deceleration from head compression. Variable deceleration from prolapse cord or cord compression. Remember both wording. And third is your late deceleration. Now before I go on late deceleration, let me repeat here yesterday. And I said, when mother is having hypertension or preeclampsia, what is the risk of preeclampsia and hypertension is? What is the risk is? Remember the word abruptio placenta. Everyone is okay. This is the way, keep in your mind. Because questions are not going to be what is abruptio placenta, painless bleeding, no. The questions are much deeper. Any question will come is more, mother is having preeclampsia, hypertension. What do you monitor your mother? She can start bleeding. And what is that word is called? Abruptio placenta. What is another word is? I just said placental insufficiency. When mother is bleeding, abruptio placenta, what is the complication of abruptio placenta? I did yesterday. And what was the complication? DIC. What is DIC? disseminated intravascular coagulation. See how you got to connect your question, not knowing one topic here, second topic, but we must know mother has, that's why prenatal mother, those who are pregnant, comes in. We got to monitor their blood pressure, monitor their weight, and check their albumin level in the urine. Why? Just to be sure they're not going into preeclampsia. You're stopping early. Because what is abruptio placenta? I will be moving in there, and then I will explain you, is a normal placenta. Everyone is okay? What is abruptio placenta is? Normal placenta. Mother has normal placenta. She should not be bleeding. But there are reasons for her bleeding. There is a difference. Placenta previa is abnormal placenta. This is a normal placenta. But why does the mother start bleeding here? Is because of hypertension. Maybe mother's health is bad, her physical conditions are bad, and she cannot keep the baby, and placenta starts separating before time. So hypertension is leading into what? Bleeding. Very important to control the blood pressure. And what will happen? Because the mother is bleeding, this placenta previa doesn't have DIC because the bleeding is going out. DIC bleeding, you may see some bleeding, but most of the blood would be in the back of the placenta. Because where is the placenta is in the upper part of the uterus. So what happened? The placenta is moving away, and that's why we say the abdomen is hard. And placenta previa, abdomen is soft because the blood is draining outward. This blood is staying back in the uterus and staying for longer time, and mother is going to go another complication, and that complication is called bleeding and clotting disorder, which is called DIC. Everyone is okay? So this is the way I want everyone. Hypertension, preeclampsia lead to what? Is abruptio placenta. What abrupt placenta we are monitoring? What kind of deceleration? Late deceleration. What are we monitoring the mother here? What complications she can go? She's bleeding, but she can go in what? DIC. What is the treatment for DIC? I said yesterday. Is a bleeding disorder, clotting disorder. What would you do if mother is having a DIC? She's bleeding and clotting. So remember, any simple word, anytime this word comes, that means the mother or patient is bleeding. It's not only in OB, DIC can be in liver disorder problem, septicemia patient can have, but anytime you see in your question, mother or patient is having DIC, immediately you know patient is bleeding. And what do you monitor? Shock. What position do you go for shock? Trendelenburg birth position. Are you going to give blood transfusion? IV? Yes. What medication we all remember? Heparin. Are we clear? So what drug are we giving here is heparin. IV you're giving. After you give heparin and it's preventing the clotting and bleeding, and then what do we monitor is, how do you know it's working for your patient? Everyone remember, you're monitoring the renal. Renal means kidney. And what do we monitor? Urine output. Okay? So that covers up about your late deceleration. Early deceleration, variable deceleration. Now I will go on underneath. You have mother, when they rupture the membrane, they lose about 1 to 3 pounds of the fluid and they lose weight. Leopold manure word is important. Sometimes they throw, that's examining the mother. How do you examine Leopold manure method is, what are you checking the mother? Mother is laying on the table, and where do they start? They start, it's a external exam. So mother is laying from the top, and they'll go with the hand, and they go on both sides and till the bottom. And what are they checking in Leopold? So what is Leopold manure in exam question? External exam. Mother is laying on the table. And what is the purpose of checking this position? Underline the word, determining the fetus position and presentation, and they are locating the fetal heart rate. Are we clear? So what is it? External exam. We are only checking outside. We are looking from the top and they're going on the side. They can feel the baby's head. Where is the buttocks? They can feel it. Then they're looking if the babies are engaged here, because when the babies are moving, they're going down here, is called engagement. So they're checking if the baby is down here. And when they're looking and they see which side is the head and which side, they can locate the fetal heart rate. So when mother comes in labor, or mother is coming during examination, and what do? Leopold maneuver. What is Leopold? Is external exam. And what are we locating here? Babies, which is called fetus, position, presentation, and you are locating the fetal heart rate, so they can hear the fetal heart rate. So that is your Leopold maneuver. I will move on to true and false labor pain. Everyone, you guys already know, so but you must know those questions. How do you know mother is in really labor? So let's just highlight the few wording here. Is in true labor pain are, number one, true labor pains are regular pain. Number one, they're not irregular. So remember the wording, regular, and when they're coming regular, they're getting stronger. Underline the word stronger. Regular, stronger, and lasting longer. That means they don't disappear, the pain is there. So what is important word here? Regular, stronger, and longer, and they come close together. They don't disappear, they keep coming. And what does it help? If it is a really true pains are, it's going to cause dilation. Cervix is dilating, and cervix is becoming effacement. What is the word is effacement? Thinning, a stretching of the cervix, because the baby is moving down. And so what is happening in true labor pain are regular word, remember stronger, and their pain is coming closer, and you will have the answer, dilation and effacement is there. Mother is dilating, and the uterus is, the cervix is a stretching. The word is called effacement. If you teach relaxation technique, the pains do not stop. Are we clear? If you relax and your pain stop, that's not a true labor pain. So when relaxation takes place, the true labor pain will not stop. And they will get stronger with walking. And where does the true labor pain start? In the lower back. That's important. So where does it start? In the back, and then they travel to the abdomen. So remember, few wording, and these are the exact wording we must know. Is number one, regularly, stronger, closer, effacement, dilation, and they don't stop. And where do they stop? On the, where do they start the pain? On the back, and they radiate or going towards the front. Second is the false labor pain. What is false labor pain? Does not cause dilation. No dilation, no effacement, and they're not regular, irregular. Underline that word. And walking has no effect. And notice, where is the pain? You will notice in the second line, fundus. Fundus means right here. If you're not having in the back and pain is only here, that's not a true labor pain. Fundus. And also, fetal monitoring. It can lead to sometimes false labor pain. Monitor for bradycardia and deceleration and hypoxia. When you're monitoring the mother for contractions and the pain, monitor for hypoxia. That means the fetal heart rate. We already did deceleration. We don't need to repeat that. So this is the same deceleration. I will go on a little bit on some pharmacological management here. When mother comes in, sedation. And Stadadol word and Nuban, we did before also. It's good, better than morphine and other, but Nuban and Stadadol is given IV and given very slowly. Nerve block, when they do nerve block, it's called local infiltration. And what are they using here are xylocaine. Xylocaine to numb and for episiotomy. We all know what is episiotomy, they cut. And that's episiotomy, they can give nerve block. and they use xylocaine for episiotomy. Pudendal block, when they do the block, they use usually second stage of labor, and episiotomy and birth time. Also pudendal block, as soon as mother is having a baby and the perineum is stretching and they're going to do episiotomy, they can give them. And also it affects the blocked nerve to the cervix, perineum, and vaginal area. Spinal anesthesia is more like going into the lumbar area in the back, third, fourth, and fifth lumbar intraspace. So spinal means they're giving in the back, it's going in the spine. And it relieves pain. Second line, what do you monitor? Hypotension and bradycardia. And because they are with spinal, unable to push. So you have to help the mother, telling her for pushing. And after the procedure, you prevent, underline the word, leakage of the fluid and headache. So write down on the side, keep the mother, after is done, is on the back, because that will prevent the leakage of the fluid, like lumbar puncture. So position should be after it's given, mother lays on the back, not on the side, because why? The leakage of the spinal fluid. So where it says leakage of fluid, they also use the word and monitor for headache, and underline the word is blood patch. Is a patch which stops the leakage, is called the blood patch. And maybe some answer, mother has hypotension, headache, what do you prevent before spinal, this procedure? Fluid, before and after. Even after they had a baby, a lot of mothers, they feel hypotension. So what do you give them? Is increased fluid. So 3 answers important. Back, lay on the mother on back, monitor for headache, and before that, hypotension, and also blood patch can be used, and increased fluid. So increased fluid, blood patch, and on the back. Epidural is also used in laboring client, does not lower a fetal heart rate, does not result complete anesthesia, does not suppress fetal heart rate, can assist in pushing. Mother can assist in pushing. When do you give epidural block? You can add there when mother is 5 to 6 centimeter dilated. They can give them epidural. And what do you monitor? Hypotension. This one, hypotension, increased fluid, and turn the mother on the left side. You can give them the blanket. So spinal is, remember, is more like a lumbar puncture. So you prevent them from headache. Epidural can be given in 5 to 6 centimeter dilated, but monitor for hypotension. I will move on labor now. In labor question, so few things you know about mothers in the positioning and what you are doing, epidural, pudendal block. Any questions on that? At least you have some idea. Now labor, mother comes in labor, there are the stages. And very important, we all know the stages of labor. And those are important, very important, your stage 1. Everyone should know good about your stage 1, and a lot of questions they throw on that. Stage 1 is called what? Dilation stage. So what is stage 1 is? Stage 1 is dilation. So remember, keep that in mind. The mother has to completely dilate. No pushing in stage 1. Only pushing would be in stage 2 in your question. So stage 1 is called dilation and effacement. There are 3 stages. It has latent stage and active stage you have, and third is transitional stage. Very important that we know. Which one is the first one is called latent. Latent means the mother is only dilating, underline 3 centimeter. And contractions are coming 5 to 30 minutes. And lasting duration 30 to 45 seconds. Very important that you guys know these few wording here. And also mother is talking. And what would you be, how frequently you should monitor the mother is in the latent stage, you can monitor the mother is every 30 to 60 minutes. 30 to 60 minutes. That means as a nurse, check the fetal heart rate, keep eye on the mother. She is only dilated is how many centimeter? 3 centimeter. And mother is still talking. You are assessing how frequently you should go and check the mother every 30 to 60 minutes. And you are checking the fetal heart rate. No food you give them, mother is in labor, you give them ice chips. And what do you encourage all the time? Mother, until she had a baby, is voiding. Are we clear? Peeing. Why? Bladder empty is important. If bladder is not empty and baby is coming out, is the injury to the bladder and stopping the contraction. So very important that mother empties the bladder every time and encourage her. Fluid you cannot give, ice chips is okay. Keep talking to the mother, encourage the mother. Number 2 is your active phase of labor. In active phase of your labor, I want you to write down, you will monitor 10 to 15 minutes. Now she's getting more infrequent pain. And the pains are 4 to 7 centimeter, mother is dilated. So now 4 to 7 centimeter. Remember the first one is latent, second one is active, and third one is transitional stage. Now active phase is 4 to 7 centimeter. Pains are coming every 3 to 5 minutes and lasting 40 to 70 seconds. Pains are getting more stronger. Mother is getting restless and anxious because pains are more painful now. And what do you do at this time? Inform the progress. Keep talking to the mother. Maybe comfort, back rub, pillow is good. Oral hygiene, ice chips is good, voiding is good. Remember, we are nurses. Your questions are going to be, what would you do during this stage? So anything looks, you can do it. And yes, you're monitoring the mother. The third stage is transitional stage. Mother would be dilating 8 to or 7, some books might say, but remember 8 to 10. She's not dilated. And they will say, mother is 8 to 10 centimeter dilated, transitional stage. Would you assist mother in pushing? No. No pushing yet. Are we clear? No pushing even because why? Because mother is not completely dilated. 8 to 10 centimeter she is. And what would you do here? Contractions are coming 2 to 3 minutes. And you monitor the mother every 3 to 5 minutes. Keep monitoring the mother. What does the mother feels? Tired, restless. She's out of control with her pain and nausea and vomiting. I want you to add there, increasing in this stage, the word is called bloody shock. Bloody shock. That means more blood is coming out. Is in the cervix, we have the mucus plug. Once the mucus plug comes off, then mother and the baby is moving down, is what? Is the bleeding is getting more, is profuse. So questions, what do you see in transitional state? Maybe you will see increasing bloody shock. Bloody shock means is more bleeding, but there, and some wording, if you will read it, it says a mucus plugs have been released and mother is bleeding. Are we clear? It's because mother is dilating more. Baby is coming more down, so you can see more bleeding. And what would you do? Some questions you have in transitional state. Now mother is more in pain. What do you do, mother? Write down the word, praise the mother. Support the mother. You're doing good. Keep it up. And that means you're encouraging the mother, praising. And also, intervention is keep the mother and partner informed. You let them know what's happening, how far she is going on. Ice chips is okay. Voiding is important. Again, if mother is paying, that's fine. And also, If women begin to push, what do? Tell her not to push and call your RN, because why? If the baby is coming out, she will have more bleeding, you need somebody else there. But what do you tell the mother? Is not to push. And are you going to encourage the mother in transitional stage? No. And a lot of time we don't remember and we don't pick up. No answer for pushing in stage 1. We do not allow the mother to push. Everyone is okay? Latent stage, active stage, transitional stage. Added the word bloody shaw in transitional stage. We keep on monitoring the mother. Stage 1, what can you do the mother when she comes in stage 1 is Leopold manure. We already said as soon as mother comes in, we are checking Leopold externally. And what are we looking here? Fetal heart rate, positioning, presentation, external. You monitor the station and position. Pelvic exam is done. Fern test, remember I talked about the Fern test and the nitrazine test. Why do we do it? To confirm the mother has ruptured the membrane. And what are we checking here is the mother has the fluid and you're checking with the nitrazine paper. And meconium stain, if you have a question, mother is membranes ruptured and the fluid has meconium stain. What do you monitor? Meconium means the baby has passed the stool. And what do you monitor? Or greenish color. That means the baby's stools are there. And what do you monitor? Your answer should be fetal distress. Because membranes rupture, baby is going in fetal distress, baby already had the first bowel movement. Assess the fetal heart rate. Very important on those questions. So everyone so far, stage 1 we talked about it, and we talked about transitional stage. Number 2, stage 2 is delivery of the baby. Now is the delivery. And what is when the delivery is in stage 2? Stage 2 is pushing stage and baby is coming out. Is mother is fully dilated now, 10 centimeter. And babies comes out at this stage. What do you monitor in stage 2? Frequently you check before mother has a baby, fetal heart rate, normal fetal heart rate, and underline the word assist in pushing. Now you tell the mother, assist in pushing. Now, what would you be is monitoring contractions. Every 2 to 3 minutes, baby is coming out. And also, you can give ice chips and baby comes out. What are the sign of stage 2? What are the sign of stage 2 would be? What are the sign of stage 2? I want you to write down. Increasing bloody shock. And cord is, what would be, is the baby. Is the first, second stage, the baby head is coming out, is you can see the bulging perineum. The perineum is bulging and you can see what the baby's head is coming out. That's a stage 2 when the baby's head is coming out. So what is stage 2 sign is? Number 1, increasing bleeding. And what else is there? Bulging perineum. It's just the wording. Sometimes they will say, how do you know mother is in stage 2? That means the baby is coming out. And before baby is coming out, the mucus plugs came out, mother is having more bleeding, and you can see the perineum is bulging, or your answer may be visible, baby's head. You can see the baby's head is coming out. Stage 3 is called, and if they ask you, when do you prepare the mother for labor? You do have some question. And when do you prepare? That means you're monitoring the mother, but when do you take her in the labor room? At there is when the mother is 7 centimeter dilated. Once 7 centimeters start dilating, you are preparing. She's not ready yet, but yes, you may have to move her in the delivery area, have all the things available for the doctor. So question, when do you prepare the mother to have a baby when mother is 7 centimeter dilated? Now, is stage 3. So stage 2, is delivery of baby. Stage 1, dilation. Stage 3 is delivery of placenta. Now, what is in sign of placenta delivery? I want you to write down on the top. The cord is getting longer and bleeding is more profuse. So what is sign of stage 3? What is stage 3? Placenta delivery. But how do you know placenta is coming out? The baby came out and the cord which is hanging is getting longer. Why? Because placenta is separating and the cord, you can see, if cord is not getting longer, that means the placenta is not separating. So how do we know stage 3? The mother is in stage 3. After baby came out, the cord start getting longer, more bleeding. Why? Because the placenta is shedding away from the uterus, and that is causing more bleeding. So increasing bleeding, and the cord is getting longer, that means the mother is, the placenta is coming out. Now, sometime you are outside somewhere and baby comes out. What do you do to help for? Because placenta is important to have coming contraction to come out. So very, very important. Delivery is the baby comes out, placenta comes out completely, then you think whole delivery completely is done. Now, if mother is somewhere and you are in emergency, what does it help in contracting the uterus? Put the baby on the breastfeeding. And breastfeeding, what does it cause? The contraction, increasing the contraction. So some of your questions are, if you are in emergency, you are in a parking lot, husband is calling for help, the baby came out, what can you help for stage 3? Maybe put the baby on the breastfeeding. When they have to start feeding, it increases contraction, helps them for contraction and removing the placenta. That's good on that. And empty the bladder. All your questions, OB, is good. Placenta delivery in that.